My name is Tony Tarr. I'm doing head-to-toe assessment, nursing 621 Maryville University. Here with my patient. Before the exam, I asked my patient to remove clothing, put on a gown, but for this assessment, he's going to just wear his shorts. We also checked measurements, his height, weight, and we checked his distant vision with the Snellen chart, which revealed that he had 20/20 vision. Also, beginning with the general assessment, this patient generally looks appropriate. In fact, just speaking with the patient is normal. I don't see any gross abnormalities on general inspection. Starting with the head-to-toe assessment, I will start with the head. With the head assessment, you're going to inspect. The steps will be inspection, palpation, and so with the head, you will inspect the skin, looking at the skin, making sure uniformity, color, no lesions, no bumps. And also with the scalp, you want to make sure the scalp is uniform, the cranium is normal shape, which it is. It would be normal cephalic. And then also so once the inspection phase is done, you will move to palpation. You're going to palpate the scalp to make sure there's no lesions, hair texture is fine, evenly distributed. And then you also want to palpate the facial bones. You're going to palpate the facial bones and the sinuses. For any abnormalities, normal, sinuses, axillary, ethmoid, frontal, all normal. Did you feel any tenderness?
No.
I didn't feel any bumps there as well. Moving on down from the face, you will go, actually, after the general head assessment or facial assessment, you're going to I'll go to the eyes. So inspecting of the eyes, you want to check the sclera conjunctiva for redness, look down, look up. No redness, lacrimal apparatus, there's no drainage, lacrimal gland. Is there any, is that sore?
No.
Okay. Eyelashes evenly distributed, upper eyelashes are pointed up and out, lower out and down, which would be a normal finding. Also, you want to notice or note symmetry. Eyes are symmetrical, in line with the tops of the ears. That's an important finding during the assessment as well. As far as tests with this eye assessment, you can check the cover-uncover test. So cover one eye, uncover the other eye, uncover. Then you want to check for any kind of muscle, any kind of nystagmus, any kind of extraocular movements, anything abnormal, and there were no movements there. And check the pupillary response. Going in from the side, pupils had direct and consensual response there. And then if you could look at my pen, now stare away toward a point on the wall, back at the pen, and then away. Okay, and you can notice with accommodation, you can notice pupillary response with that as well. And if you could follow, look here at the tip of my pen and follow. And then follow. Okay. That is noting the 6 cardinal fields of gaze. That can also be assessed during a cranial nerve assessment. Next, after you check pupillary response, cover uncover, you can check. You also want to check the red reflex. For this, you're going to use your ophthalmoscope. Make sure it's on. In. Notice the red reflex in the eye there and look towards me. Red reflex is noted there as well. You want to make sure that you do perform that bilaterally. Next portion of the assessment is going to be the ear assessment. Here, inspection phase, we're going to inspect the outer ears, look normal, palpation, no bumps, no lesions, both appear symmetrical, and you can use your otoscope. You want to inspect the inner ear. Tympanic membrane is pearly gray. Notice the light reflex. Hold the pin up and out. Same with this ear. Also, you also want to note the cerumen in the inner ear, which was noted bilaterally. There shouldn't be to the point of infection, but there was noted in the middle ear canal on this patient. Also, some tests after inspection, you want to check the Weber-Renée test and also the whisper test. So when check whisper, if you could just repeat the word after me, close your eyes, cover your right ear.
Dog.
Move the other side.
Cat.
Okay. And then the Weber test, will test bone conduction, strike the tuning fork, place. Can you hear the sound in both ears? So that would be a normal finding. Renée test, you strike the tuning fork, place on the mastoid process. Tell me when you stop hearing.
Okay.
And move. Tell me when you stop hearing.
Okay.
It's testing bone to air conduction. Air conduction should be double that of bone, and you should time this while you're doing that. With this patient, I noted 10 and 20 seconds, so bone versus air conduction, so that's normal. You want to do this test bilaterally, strike the tuning fork, place on the mastoid process. Tell me when you stop hearing.
Yeah.
Tell me when you stop hearing.
Okay.
Again, noted roughly 11:23 seconds, so also another normal finding. Next I will move to the mouth. You want to check the lips, check symmetry, color, no cracking. We will check the inside. The patient's mouth, we're going to inspect. Colors pink, moist. Patient has all of his teeth, no dental caries noted. If you could say ah.
Ah.
Then you also want to check the gag reflex by placing a tongue depressor in the back of the patient's throat. Both are normal findings with this patient. Let's see. Also noted with the when you're doing the mouth, you're noticing the soft palate and the hard palate, both noted. When the patient says "ah," you're going to notice the uvula rise, and the tonsils you want to grade. This patient's tonsils were about a 2, and he still has both tonsils in. So let's see. Next part, palpating. We're going to move down to the neck. First, actually, before the face, I'm going to palpate his lymph nodes, preauricular, posterior auricular, occipital, moving down submental, submandibular, moving back tonsillar, moving down his neck. You're going to note the superficial cervical chain, deep cervical chain, posterior cervical chain, supraclavicular, infraclavicular. Also, you can check axillary. Have the patient lift his arm, palpate axillary, lymph nodes, and no abnormal findings there. Also, when you're doing inspection phase, the inspection phase of the neck, you want to look at the neck, make sure lesions, color, normal, midline trachea. If you could look up, and I want you to swallow. Okay, and then look up and swallow again. And palpate the thyroid gland. Trachea is midline. I'm going to auscultate. Actually, I'm going to palpate the carotid arteries first, one at a time. Right, left. These are noted 2+. Auscultate the thyroid and the carotids for bruits. You can take a deep breath in and hold it. Okay, let go. Deep breath in and hold it. Okay, and then just breathe normal. You take a deep breath again and hold. Okay, so no bruise heard over the thyroid or the carotid arteries. So after moving down, actually with the neck assessment also you know range of motion. So you can have the patient look towards me, look the other way, look up, look down, touch your ears to your shoulder one side at a time. Tilt. And you want to notice any abnormalities or decreased range of motion there. Next, moving on down the body, we're going to do the chest. We'll do posterior first. If you could spin towards this way. Posterior chest inspection, you want to note symmetrical movement, even unlabored respirations. Note the costovertebral angle here. You want to note the rise here. Take a deep breath in, out, in, out. Normal. Inspection phase. Next, you can palpate. Palpate for any abnormalities. Also with the skin, when you're noting this patient has some scattered nevi throughout his back, which is normal finding. Next, after you palpate, you want to percuss over the lung fields. Systematically. Also, you can check for diaphragmatic excursion. Take a deep breath in. Check for change in from tympanic to a dull sound. And then palpate up, or percuss up. At these two marks, you want to measure. You want to measure 5 centimeters, which is normal. A normal measurement on that would be 3 to 5 centimeters on the diaphragmatic extrusion. And you want to do that bilaterally. Deep breath in. And then measure 5 centimeters. Auscultation is next. Auscultate over the lung fields. Take a deep breath. Out, in and out. All lung sounds were clear. You can check the lateral chest wall. You can inspect. You also want to inspect the anterior posterior diameter. You want to make sure the patient is not barrel chest, which he is not. Palpate the lateral chest wall. Percuss it as well. And then also auscultate the lateral chest wall. And normal lung sounds were noted on the lateral chest wall. Also, with the costal vertebral angle, since I'm on the posterior side, you can check percuss over the kidneys. Feel any pain there?
No.
Which would be a normal finding. Okay, you can slide back around this way. So next, we'll do the anterior chest wall, both respiratory and the cardiac assessment, starting with assessment, making sure lungs are even, symmetrical respirations. We've got a palpation. No abnormalities. Palpate the precordium. Also, apical pulse, fifth intercostal space, mid-clavicular line. And apical pulse is normal there. After palpation, you can go to the percussion phase, same on the front side. Palpating in the intercostal spaces there. And then lastly, auscultation. Take a deep breath. Okay, now listen to the lung sounds. You can just breathe normal. Aortic, pulmonic, Herb's point, bicuspid, or actually tricuspid, bicuspid. All normal, S1, S2 noted, no S3, S4, which would indicate abnormal finding. Also, or actually the next thing with moving down the head to toe assessment would be the abdominal assessment. For this assessment, you want to have the patient lay flat. So inspection phase of the abdomen, you want to look for any abnormal pulsations, make sure the belly's flat. Light palpate. Oh, actually, I'm sorry. Important to note with the abdominal assessment is first inspection, second is going to be auscultation. You want to auscultate second. All 4 quadrants, noting for bowel sounds. Also the arteries, aortic, renal, iliac, and femoral. You want to note any bruits over the artery auscultations, and I didn't hear anything over any of those arteries. Next, after you auscultate the abdomen, you want to percuss all 4 quadrants. Normal tympanic sound there is especially noted over the stomach. And then liver borders, you can percuss up to abdominis, mark, and percuss down to sound change from that point. Go there, measure 8 centimeters, which a normal liver 6 to 12 liver border. So that's normal. Next is splenic dullness. You can check during palpation. Noted here. Normally located around the 9 to 11 intercostal space. You're going to take a deep breath. Any tenderness? No. Okay. After the anterior chest here, you can palpate the kidneys. You want to place your left hand under the back. Take a deep breath in and let it out. Same with this side. Deep breath in, let it out. You should be able to palpate both kidneys. The liver borders, palpate by pushing up on the patient's posterior chest. Have them take a deep breath. It's noted right under the right costal. And the left side, deep breath in and out. Barely notice the spleen on the left costal margin. Also, with abdominal assessment, you can check with, you can palpate for hernias. You can have the patient cough, cough, cough. No noted hernias with this patient. And finally, you can palpate the aorta in a pinching manner up from the umbilicus and make sure there's no abnormalities there, which seem to be normal. Go ahead and sit down. Let's see where we got on time. 23 minutes. Okay. So after abdominal assessment, we can do the extremities. You know, for color, note for hair distribution, note for pulses, radial, brachial, bilaterally. Those are noted. Same with the feet. Also, with the upper extremities, you look at the nails and make sure there's no clubbing, no cyanosis. Looks good there. Legs, no edema. Hair distribution, normal. Pulses. Dorsalis pedis up top. Posterior tibial. Dorsalis pedis. Post-tibial. And popliteal behind the knees. Noted. Also, with the lower extremity assessment, you want to assess for any kind of edema, vertebral edema, and there's none noted in this patient. Lastly, we want to check musculoskeletal assessment. We have the patient put his arms out in front of him, try to raise your arm against my pressure. Be strong there. You can hand grasp, squeeze my hands. Strong, lift legs, other leg, push against my feet. As strong. You can do shoulder shrugs, which can also be pushed down. That's a cranial nerve assessment as well. That's the cranial nerve 11, the accessory cranial nerve. Let's see if I miss anything. I guess lastly, after musculoskeletal, this is an optional. I wanted to go through the cranial nerves quickly. The first cranial nerve is the olfactory. You have the patient close their eyes. Tell me what the smell is.
Peppermint.
Guess that correctly. The second cranial nerve is the optic cranial nerve. We tested that during the eye examination. That's done with the Snellen, Rosenbaum, those visual acuity tests. Third, ocular motor. 4, trochlear. 6, abducens. Those are all checked through the cover, uncover, and pupillary response accommodation. Trigeminal nerves. You can test that with sensation on the face. Close your eyes and tell me if you can feel.
Yeah. 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 Yeah.
Just use cotton for that, something soft in each part of the face area there. The acoustic nerve is cranial nerve number 8. We tested that during the ear assessment with the Weber and Rennie exam. The 9 and 10, that's the glossopharyngeal and the vagus nerve, that was tested during the oral portion of the exam with the eliciting the gag reflex and the patient saying ah. Number 11 is the accessory cranial nerve. That is tested with the shoulder shrug test that we did, placing your hand on the patient's shoulders and having resist against that. And then also, and lastly, the hypoglossal. You can have the patient stick out their tongue and then move it toward your chin, up to your nose, to the side, other side. And then lastly, you can try to have them move their tongue against the tongue, stick your tongue out, try to move it against, okay? And note that the strength bilaterally is there. And then I also, with the musculoskeletal, I forgot, you can check the feet tendon reflexes. You can check the brachial. You can have the patient rest his arm at a 40. Actually, can you stand here back? Arm rested. Notice the movement there. Lower arms. You can check the patellar reflex. If you can dangle you're going to strike with a reflex hammer right below the knee, patellar tendon. And then if you can scoot back, we'll check the Achilles reflex, left leg, and then push against the foot, and then notice movement in the calf. That should be the conclusion of my advanced head-to-toe assessment. Thank you very much for watching.